true to the best of your knowledge and understanding, and that you wish to stand as your evidence for the Commission?
Correct, and I do.
What I'd like to ask you about first is your role in shaping a healthier future. Can you explain to the Commission what your involvement and remit was?
Indeed. So I represented the Royal College of Surgeons of England to give advice principally about emergency surgical provision within the sector.
And when were you last? When were you last involved in the board in that role?
Approximately 6 months ago.
And at that point, were you broadly supportive of the aims of shaping a healthier future?
So the aim, I must preface that remark by saying that I need to stick to surgery. And I am well aware, particularly having listened with great interest to the last witness, that in fact surgery, particularly emergency surgery, is a very small part of total healthcare provision. It sometimes gets an unequal share of the action because it's exciting in the true sense of the word, it's expensive, and the people who talk about it often talk quite loudly and forcefully. Nonetheless, it is a small component of the whole. So my role was relatively small and narrow, but did concern a very important part, nonetheless, of healthcare provision in terms of quality.
So limited to the area that you were directly involved with, were you, as far as that area is concerned, supportive of the reconfiguration and the aims that were being promulgated in this programme?
Absolutely.
And at that time, was it your view that the reduction, and you may say this is outside your remit to comment upon, that the proposed reduction from 9 major hospitals with all services to 5 major hospitals was a proper approach or not?
I would, for the purpose of providing the quality of emergency surgery, principally because of the standards that surround such provision. Those standards were then being developed by Healthcare for London, and I worked with them as one of the team that looked at appropriate standards for emergency surgery.
Did you at the time think that there could have been other equally legitimate solutions to that proposed?
So if we talk about what those standards are, the solutions become clearer. The most important thing is for an acutely ill surgical patient, and indeed other patients, to have the benefit of a consultant opinion within a reasonable time of their admission, which was set to be 12 hours. And surrounding that admission, there needs to be the sort of service that we would all want and expect in terms of radiology. In terms of radiology, in terms of interventional radiology. And of course, this requires a lot of personnel and equipment to be co-located. And the only solution to providing this bit of medical care, this bit of emergency care, must be from your centralisation. And after all, we're not talking about Suffolk or East Anglia here. We're talking about a relatively small geographical area. Now, when we make these pieces of advice, and this was not just the Royal College of Surgeons, but Hammersmith London, and those stipulations, those standards, were surprisingly congruent amongst between those two bodies. One has to be aware of the unintended consequences of making such statements. Certainly, however, such a reduction to 5 centres in terms of acute surgery could only be the right thing to do.
And that remains your view?
That remains my view.
Now, you say in your document that the reconfiguration board considered sites but assumed that the trust responsible for the reconfigured site would manage the diverted cases on their remaining facilities.
Correct.
I wonder if we can break that down and you can help us with this. What sites did the board consider and what, if any, conclusions did it reach?
So it considered the imperial sites as being one. So that and I'm talking for emergency surgery. In terms of emergency surgery, it was considered that Imperial, responsible for those 3 sites, would make suitable arrangements to deal with the emergency surgical workload. It was assumed, most probably, in the majority of cases, on one of those sites, because it was assumed particularly that Hammersmith, which was not an emergency surgical site at the time, would certainly not continue as such. So the board's deliberations assumed that policy for Imperial, not dissimilar from what had happened with the North West London hospitals, and they regarded Northwick Park and Hillingdon as being outside a networking capability because the distances were too far to allow an easy cooperation. So within the centre, Imperial was one unit, North West London Hospitals was another unit, Chelsea and Westminster and West Middlesex were separate, and at that stage were considered as being apart.
So that was the assumption, that's what the board considered. Are you able to help with why the board was confident in that assumption?
Could I ask for voices to be kept up a bit? Sorry.
Yes, I'm so sorry.
Why was the board, sorry, why was it the board felt that it could make those assumptions could be relied upon? That's probably now.
I can't really answer why they thought they could be relied upon, but it was not an unreasonable assumption, being in the room at the time, to imagine that one of the sites within Imperial, particularly that one designated as a major trauma centre, would also be entirely competent to deal with emergency surgery.
Were there any assurances given by any trust members who were present that that would be the case?
I can't answer you that because I wasn't at every meeting.
Were you aware of any assurances given?
No.
Was it explored, and you may not be able to answer this, was it explored with those members of the trust who were present that those assurances might not be correct, that it might not be the case in fact?
There was a part of the clinical board, a group within it, who considered emergency services as a generalist, not just surgery. I wasn't party to that group, but I think it is my impression and my view that they took that matter seriously. Where their advices came from, I am not sure.
Are you aware of whether or not any specific assurances were given by Imperial in respect of the removal of acute services from Charing Cross Hospital?
I am not.
Are you aware if there was any evidence provided by Imperial to underpin the assumption that St Mary's would be able to accommodate all of the cases which were coming in their direction?
I am not aware of such evidence.
Now, you set out in your short paper a number of changes that have occurred since your involvement which have impacted on your thinking. Now, could you expand, please, on what you say has changed, first of all, with regard to emergency surgical volumes? Do we know why the increase, and do we know what the size is?
We know neither of those things. We can adduce that this has happened by an increased demand for level 2 and level 3 care, that is what is also known as high dependency HBU and intensive care, that's level 2 and level 3. We can adduce that. We can adduce it from attendances in A&E, although it is quite difficult to separate acute surgical attendances which relate to abdominal surgery from the others, quite difficult in terms of coding. I believe that currently, at the present time, the board is trying to look at current evidence, contemporaneous evidence, for the number of acute abdominal surgical cases that are entering the hospitals in the sector. But you have to do that by HES codes, and that, as I say, is not easy. The present time, the College of Surgeons of England is doing a laparotomy audit, which may throw some light on the question that you just answered. For there is a suspicion that this type of work, this type of surgical emergency, is increasing nationally.
That's not something you would, I think you use the word suspicion carefully. It's no more than that at the moment.
It is no more than that.
Complexity and comorbidity, again, that's another area you identify. Again, is it increasing? And if so, do we know why and by how much?
We know that it is increasing. We think we know why, because that's the trouble with all doctors, as they get more senior, we're almost sure we know why, but we think we know why, and that is because the population ages and techniques do improve, and therefore you tend to operate on your patients.
And is there any, are you able to assist with any degree about the scope, size?
So you can, well, you can reduce this within specialties. So for example, if you look at my own specialty, the number of people, the number of patients, mostly elderly, who can undergo a very major intervention to have their bladder removed, for example, is increasing significantly. By how much? Over the last years, over the last 3 years, by approximately 10%.
Now you also talk about capacity in the region being saturated. Can you help us with whether this was foreseeable, and if it was, why it was not foreseen?
It's the Donald Rumsfeld question. Foreseeing the unforeseeable.
With yes, yes.
So I think that the board attempted to come to the right judgments about acute surgical care, particularly in terms of those patients who might need the level 2 and the level 3 care. Because within the board there was a separate group who looked at intensive care and looked very, very closely to see what would happen if you moved intensive care facilities around the region and took some of them out, and what would be required to be reprovided, to be increased on the remaining sites. And this was a very careful piece of work. It was orchestrated by intensivists, and these weren't people who had any other interest than to get intensive care right. So these were intensivists from the existing trusts. The expenditure in order to relocate and recreate these facilities was quite considerable. And they built in a little bit of extra capacity for this new network. So I think that that was a right-minded piece of work. I don't think contemporaneously, I went to some of their meetings, that they were underestimating, because all of those clinicians, frontline clinicians, know that if you underprovide HVU care for acute surgery, then you end up in a far worse place. It's more expensive, the outcomes are worse, it's a disaster. So that piece of work was right-minded. I think it was based upon correct fact and probably a correct prediction. But once again, we're talking about this work having been completed about 18 months ago.
And since then, I suppose the question is, but then.
Well, since then, I think if you wanted to update that particular evidence, a good place to go would be the intensivists who made those predictions. That would give a fairly accurate view of the probable increase in acute surgical activity over the last 3 years.
And so the conclusion that you then draw, that at the moment capacity requires all of the imperial sites.
In order to maintain the elective, the major elective surgery and the emergency activity, it is difficult to imagine that the facilities that are currently used will not need to be continued to be utilised to their full.
If the reconfiguration continues and the proposed changes take place, what's the likely effect on the areas you've talked about?
So it is clear that what is currently available, I'm talking about acute
Sorry,
surgery.
could you keep your voice?
I'm
Very
trying to look
I
at
know.
the question. So it is clear that the currently utilised facilities would need to be provided at the same level, indeed at a greater level, on the new reconfigured sites.
So finally, what should happen now?
So what is happening, what I can tell you, although I am representing the College of Surgeons, and I'm glad that I have not been harassed by Imperial. I don't think I will be. But currently I can bring some news from at least one of the Imperial sites, which is that I'm pleased to report that there are currently adverts.
Can I ask if you're going to report something, if you could perhaps keep your voice up, because it's strange to hear something that you see as good news.
So this is good news, that there are currently adverts which I have seen for the appointment of 3 new general abdominal surgeons at Imperial. This increases the numbers to a level at which I believe that the very important standards that we started with should be possible. I should add, of course, that when I visited many of the trusts in London for healthcare for numbers, it was then called none of those trusts were meeting those standards. So there is a London-wide problem which primarily requires to be addressed by the appointment, I know all senior doctors say this, by the appointment of more of our tribe, but that is nonetheless a true statement. And I'm pleased to report that currently there are those 3 advertisements extant.
Thank you. I have no further questions. If you've got any other questions,